Thank you. Hello. So I am Katerina. I represent the Valencia Node. So we is actually the second. Can I? Okay. Because I was a little bit okay. Okay. So it's the second time actually as a node being here, but it's my first time representing the node. So I would like to give you a glimpse of what we do into our daily practice, and actually to give you a real life example by using one of our ongoing projects, the ProCAncer-I project. So we are actually biomedical image analysis group that belong to an institution that belongs to a hospital. So we were founded a little bit more than 10 years ago by Dr. and Professor Luis Martí Bonmatí. Besides being our mentor and principal investigator, he's actually also the director of the radiological department of the hospital La Fe. So this is actually the biggest hospital in the Valencian community, and every day there, more than 1,000 image studies are being acquired. So besides him and me, we are about 42 people that work there. Our background is mostly engineering, so we have biomedical engineers, we have data scientists, AI engineers, software engineers, but we also have some radiophysicists. We have people working on clinical trials, and also, of course, our management group. And we are actually being involved on many projects, both international, national, and even our own projects. And some of them I think you've heard of before, like Radioval from ILVA or EUCAIM from ASTA before. So we are actually one of the coordinators of the EUCAIM project. And we're also coordinators actually of the Cynthia project, which is for synthetic data generation. Regarding our facilities, we have some MR, micropet, and CT scans, and we also have two nodes of 8 GPUs each for our computational needs. And now, with let's say the short presentation, I would like to move on to how we manage the data within the group. So, as I said before, we are a group that belongs to an institution, that belongs to a hospital. So our data actually come from the hospital, from the patients that come there to be scanned and diagnosed. So let's say the procedure for us to acquire the data is that our data scientists have to go to the institution, and this institution actually has to go to the hospital to take the data. So just to understand it a little bit more, on the right side, you have the services of the hospital, the ones in blue. And as you can see, these are totally identifiable data. So here we're talking about patients with name, with health insurance numbers, with phones, even addresses. So these are then standardized in the more common data model, and they are put to a database within the institute. So here we pass from a totally identifiable data to a pseudonymized data, and then our data and software engineers are actually in charge of anonymizing fully the data and putting it into our local storage nodes. So once we have our data to our, let's say, disposition locally, what we do is to analyze them. So this is actually the main part of the presentation that I would like to show you. I hope it's not too much. So once we have, let's say, the source images, the studies, what we do is to prepare those images. This means that we filter them, we enhance their quality, we also register if necessary, and we perform also some segmentation. So for the filtering, what the filtering does, of course, is to remove any sort of noise and also make the image more smooth. So here, for example, you are seeing a T1 image of the pelvis. And as you can see, the input might seem good to you, but actually the intensity is not quite homogeneous. So obviously, for me, obviously, on the other side, you can see that the output of the image is much more clear, and the signal intensity much more uniform. So for this to be done, we follow a step a series of steps. So we move any kind of noise that comes due to the movements of the patients. So even the slightest movement can cause actually quite a lot of noise. Also noise due to inhomogeneities, due to issues in the scanners, low frequency noise, any type of noise. And then we perform the segmentation. So what we segment normally is either the entire organ or part of the organ, or in most of the cases, we segment the lesion, so the scar actually that the tumor leaves to the tissue. For this, there are many architectures. We mostly use 3D units, but I will not stay to this part because we will present our, let's say, segmentation tools in the Image Data Community Days. I think there's no need to say more about that. So our slot would be on the medical image data on Thursday, April 10th, 1 to 4. And then once we have, let's say, our image nice and clear, and we have our segmentation, what we do is the main analysis of the image. So we both develop models just by working directly on the image, but we don't prefer that. We normally prefer the radiomics extraction because the radiomics extraction actually means more explainable models for the clinicians and also means less computational needs for us. So for the radiomics extraction, for those who don't know what a radiomic is, radiomic signature is actually a quantitative biomarker that allow us to characterize the morphology or the shape of the tissue under investigation. So, for example, by analyzing the histogram of the intensity, we can see whether the surface of the tumor is smooth or not, or anomalous. So if we have, for example, a homogeneous intensity, we assume a smooth surface, but if not, an anomalous. And an anomalous tumor means a more aggressive cancer. So things like that. So we can either just use the radiomics on their own, and we're talking about tabular data, but we can also mix them, for example, with deep features that are extracted from the bottleneck layers of the segmentation models. We can even use clinical data, which are normally available because we acquire our data from the hospital, so they have the e-health records. We can even use genomics if available, or even pathology if we have any tissue extracted. And once we have oral data collected, we move to, let's say, to the prognosis or diagnosis models. So this is where the AI steps in this presentation. So the preparation of those models has actually its own workflow, but it's really, really small and quick. So the first part would be the curation of the tabular data. This includes tasks such as the imputation of any missing values or any encoding, standardization, and of course the harmonization of the radiomics, which is actually one of the most important steps when we're working with radiomics, especially with data coming from different centers or different scanners, different software versions. And once we have this done, we move to the feature selection, where there's a plethora of algorithms to choose from. And then we finally move to the selection of the final model. So this selection depends both on the type of, let's say, of the problem that we want to solve, but also to the data themselves, their size, their distribution, and many other factors. And once we have our model selected, what we do then is to split our data. So we normally hold out a set just to train the model, to test the model once it's been trained. And then we further split the training set into the training and the validation sets. So I forgot actually to put a slide here, but there's another final step, which is the explainability step. So for the explainability step, once we have our algorithm, what we do is to extract either the weights of the algorithms or perform a Shapley analysis so that we understand which are the most important features and how actually they affect the predictions. And one of the most important and most neglected actually tasks that we perform is the clinical validation. This was mentioned actually before also in Milva's presentation. didn't flourish due to time issues, but hopefully we can talk about it further later. So what we do then is to sit the radiologist and make them do what they always do, just to perform a diagnosis as normal. Then we wait for, let's say, a blank out period, which is normally at least 6 weeks. And then we sit them again. And besides their images, we also show them the outputs of the model. And then we measure parameters such as, for example, did it take them less time right now that they had the outputs of the model? Did it improve their sensitivity, their specificity? Do they trust actually the outputs of the model? And then we also measure differences between the impact of the output of the models to, let's say, entering level and very experienced radiologists, because like there's actually an impressive difference with the experienced radiologists being more confident. So this was, let's say, a very generic presentation of what we do, and it actually represents the work of my entire group, which unfortunately couldn't be here. So now I would like to show you a more specific example with the ProCAncer-I project. I chose this project actually because this is the project that is finishing in 4 days. I would like to give him its last moment of glory. So this is a mostly European project, which the principal objective of which is to improve the attention in prostate cancer's continuum, that is from the moment of the diagnosis to follow-up or the active surveillance. The milestones have been actually the funding of the ProCANcer-I, which is the largest repository in European scale for prostate cancer, for prostate biparametric MRIs. So currently it has a little bit more, I believe, than 15,000 prostate images, not all of them with prostate cancer, but prostate biparametric MRIs. The development of some AI models, both for lesion segmentation and in order to solve some clinical scenarios. And also the platform for the clinical validation that I was talking about in the last slide, which actually finished 2 weeks ago, and we're now, let's say, on analyzing the feedback from the radiologists. So one of the scenarios that we had to solve for this case was the cancer aggressiveness. So this is actually a binary scenario, low aggressive cancer, high aggressive cancer. And we used a little bit more than 5,000 patients from 13 clinical centers from our partners. So the vast majority of those patients actually had good for them, bad for us, but low aggressive prostate cancer. And most of the lesions were found in the peripheral zone. So we used the T2-weighted images and the diffusion images, and we extracted segmentation masks, as I've very briefly talked before. And the analysis is pretty similar to what I've presented. So we extracted the radiomics, we mixed it with some clinical variables, and then we followed this, let's say, pipeline that I've shown with the radiomics harmonization, encoding, standardization, and low and high level feature selection. And then we actually opted for ensemble model because they handle better the data imbalances. And we performed nested k-fold cross-validation. And because we really had a serious problem with the data imbalance, we performed some mitigation techniques such as oversampling and class weighting. And then before converting the probabilities to 0 and 1, so low aggressive, high aggressive cancer, we asked actually the radiologist what is most important for them. And they told us that they do not actually, like, they do care, but they do not care so much for the model detecting the low aggressiveness case, but what they do not want to happen is to mistakenly classify, let's say, a high aggressive case as a low aggressive case. So they do not want to miss any high aggressive case because this would significantly aggravate the, let's say, the therapy and the prognostics of the patient. So we played a little bit with the threshold, and this meant actually higher sensitivity of the model. So we put a threshold to 90% of sensitivity that led us to a threshold for the probabilities of 0.46. And these are very quickly our final results. So you can see that we have really high sensitivity, but at the cost of very low specificity, which was actually inevitable due to the nature of the data and the model. Still, the vast majority of one are the high aggressive case. So the vast majority of them were correctly classified per petition of the radiologist, but we lost a lot on the low aggressive cases. We had an area under the ROC curve of 0.75. And we did this with just 7 features, with 6 of them being radiomics and 1 being clinical feature. So this was actually the whole presentation. Thank you very much for your patience, and I hope I haven't been too much. Thank you.